We'd like to welcome you to this session of the Missouri State Podiatric Medical Association Infection Control Requirement Presentation. In this section, we will discuss infection control, and we will discuss the requirements in the state of Missouri. As you may or may not be aware, licensure renewal in the state of Missouri does require periodic training in the area of infection control. The specific regulations state that the podiatric physician has a responsibility to ensure, as best as one can, efforts be made to guard against the transmission of communicable diseases. This includes periodic training of the podiatric physician in the area of infection management and infection control, with 2 hours obtained during each educational cycle. Some of the things you may or may not know, the requirements include a stipulation that a written protocol be available in the offices of the podiatric physician, basically outlining the steps being taken and required in that office to guard against the transmission of infectious diseases and communicable diseases. This includes the fact that every member of the podiatric staff is, by definition, to be adequately trained. And this includes not only the professional staff, but the non-medical staff, and that some recording be made and is available for inspection of that training that has been received. This includes the disinfection and utilization of equipment such as ultrasound machines, x-ray equipment, chairs, and so forth, with which patients may be in contact. When the podiatric physician utilizes sterilizing equipment in their office, usually this will be in the form of an autoclave, that protocols as recommended by the manufacturer are being followed, and that there is again some documentation that these protocols are in fact being followed. If some break in protocol occurs, or if the patient or office is exposed to some contagious disease, a log is to be maintained in the office of the podiatric physician, and that includes a variety of facts that must be in that log: a summary of the exposure facts, the date and time of the exposure, some form of HIPAA-compliant, unique patient identifier, the response that was taken, and then the long-term outcome. For example, this might be a staff member that was injured with some sharp object in a patient with hepatitis or HIV. The log is to be reviewed on a monthly basis and maintained for a total of about 3 years. Similarly, logs showing the following of protocol for sterilization equipment, most commonly an autoclave, should also be maintained in the office for approximately 3 years, and dictated records of the patient's, the staff training for 3 years should also be maintained. Now on to the subject of the protocols for sterilization and disinfection in the office. The objectives of the discussion are listed here. This includes an understanding of the difference between sterilization and disinfection, proper use of disinfectants in the office setting, and a look at some of the CDC recommendations regarding sterilization and disinfection. I want to begin with one of the more common areas of concern, and that's the use of multi-dose vials. And in the podiatry office, as in many medical care facilities, multi-dose vials are very commonly used. This might include corticosteroid injections. It may include local anesthetics. It includes the use of alcohol injections and perhaps other agents that are utilized. With reference to injections, a number of outbreaks of both viral and bacterial infections have been reported over recent years as the result of the use of both single and multi-dose dispensers, period. The majority of these actually occur in outpatient settings rather than in the hospital itself, and literally hundreds of infected patients have been reported. Interestingly, about 1 in 20 healthcare providers actually acknowledged that they had used a single-dose vial on more than one patient, which was certainly not the intent of the single-dose vials. And it's been suggested that many cases of viral infections, such as hepatitis C, are in fact a result of unsafe injection practices. We have seen news reports of such outbreaks of both viral and bacterial infections. This particular news report was out of a Nevada endoscopy center, where reused syringes and reuse of single vial medications on multiple patients resulted in the apparent transmission of hepatitis C. And of course, this is certainly not acceptable protocol. Again, this particular outbreak reported in the Toronto News with the outbreak of hepatitis C from unsafe injection practices. So what's the issue with multi-dose vials? Well, of course, patient safety is always our first priority in care of any patients. We've seen as a result the initiation of various hospital policies regarding the use of multi-dose vials, and there are medical and legal consequences. I recently participated in a malpractice case as a defense, and in that case, a post-operative infection occurred in a patient who had surgery done at a surgery center. And the plaintiff's attorney produced a hospital document, the hospital governing the surgery center, stating that when mixing various agents in one syringe, as podiatrists frequently do, for example, will draw up a short and long-acting local anesthetic, that this should only be done under certain conditions, and where there is a lot of traffic, such as in an operating room or hallway, the drawing of multiple agents into one syringe was not permitted. As a result of this, the doctor was sued, and one of the allegations was that the violation of this hospital policy resulted in the potential introduction of the bacteria causing the post-operative infection. Now, while this is certainly a far-fetched theory, nevertheless, it was an issue that was raised. So, patient safety is certainly critical. The accreditation status of your office, your license, your certification can sometimes be at stake. So when we utilize multi-dose vials, we want to remember that these are agents intended for injection. They contain more than one dose of the medication, and multi-dose vials should be labeled as such. So it should state that this is in fact a container intended for a multiple use. They typically have an antimicrobial preservative in them, but you want to remember that the preservatives do not affect viruses, they only affect bacteria, so that if we were to introduce a viral contaminated needle within the vial itself, we have no protection, so that we want to make sure that we follow safe injection practices. It's generally been recommended that whenever possible, multi-dose vials be restricted to use on one patient only. This is certainly not mandatory, but that's a general recommendation, and that these multi-dose vials are kept in an area removed from patient traffic. It's been suggested, for example, that multi-dose vials not be kept within the operating rooms or procedure rooms or on procedure anesthesia carts or even in patient rooms, and that if possible they be dedicated for use only for a single patient. We all know that if we follow unsafe injection practices, for example, not changing syringes or needles and reintroducing syringes and needles back into that multi-dose vial, we certainly run the risk of spreading viral and bacterial contamination, and hopefully we are not following unsafe injection practices. So unsafe practices include reusing syringes for multiple patients, reuse of syringes to access shared medications, administration of a medication from a single dose vial to multiple patients, or the failure to utilize aseptic technique, and that is preparing the injection or unsafe technique in administering an injection. And I think it's always important to document as part of your dictation that aseptic technique or standard office protocol was followed. How long should we keep multi-dose vials available for use in our office or on patients? Anytime there's a question as to whether or not there was potential contamination or break in normal protocol, then the multi-dose vial should be discarded. Generally, the recommendations are that multi-dose vials are good for 28 days once they've been opened, unless there's a specific statement by the manufacturer to the contrary. So in some instances we may have agents that have a shorter life expectancy or longer expectancy. Now if you have a multi-dose vial that has never been opened, never been punctured, then the manufacturer's expiration date represents the date that we want to discard those vials. But remember, expiration dates refer only to unopened multi-dose vials, and again, once we've punctured or utilized a multi-dose vial, it's suggested that 28 days represents the useful time for these multi-dose vials. As far as tracking these goes, one can place a label or other identification mark on the multi-dose vial indicating the discard date, that is to say the expiration date. There are also a variety of adapters that can be purchased for use in multi-dose vials to again minimize the risk of contamination, minimize the risk of infection. But in general, 28 days following the initial puncture is the expiration date, and again, if not opened, the manufacturer's recommended expiration date is the date for which multi-dose vials should be discarded. So our first question in the Missouri Infection Review, true or false? Once used, multi-dose vials should be discarded after 28 days. True or false? The answer is, of course, true. Multi-dose vials should be discarded 28 days once they have been punctured. Now, what about single dosage vials? As the name implies, these are approved for use on one patient only, and using a single dose vial on multiple patients is considered inappropriate. And the reason for this, or at least one reason, is the fact that typically single dose vials do not contain the antimicrobial preservatives that are found in multi-dose vials, and therefore there is much higher risk for contamination and colonization. Single dose vials are intended to be discarded once they have been utilized. Now, in using any type of container, we want to utilize a disinfectant on the rubber septum that covers the vial. Generally, iodophors can be utilized, or alcohol of some type, 70% isopropyl alcohol, or some approved antiseptic. Now, there have been occasional contrary opinions to the discarding of multi-dose vials after 30 days, so it is not as though there is not some argument contrary to this policy, but the general really recommended policy is that these multi-dose vials be discarded after 28 days. I'd like to move on now to the not so exciting but very important subject of disinfection and sterilization in our office settings. And again, our obligation as podiatric physicians is patient safety first, and to try to prevent the spread of infectious disorders in these patients. So a few basic definitions. Disinfection. Well, disinfection is the destruction of microorganisms and their toxins or vectors by direct exposure to some chemical or physical agent on the skin or outside of the body. And they may not be sporicidal, but may be sporostatic. And of course, we want to remember that some bacteria and viruses can go into a spore state, and a disinfectant can be sporostatic, that is to say, stop the growth of them, but not necessarily kill spore-forming organisms. Some of the other definitions is disinfectant time, and frequently the disinfection time will be listed by the manufacturer either on the disinfection container or with some printed material, but the disinfection time is the time after application of a disinfectant that's required in order to achieve its maximal effect in killing bacteria and viruses. The disinfection time obviously is dependent on the concentration or potency of the disinfectant and what it is that you're trying to kill, since certain organisms will be more resistant to disinfection than other organisms. The term terminal disinfection refers to the disinfection of a room. For example, one might, perform a procedure in the office, and it turns out that a great deal of pus is found to be present. Perhaps it's a patient with a known viral disorder, a patient with known MRSA. In those cases, we may want to terminally disinfect the room. So here's our second question, true or false. Disinfection time refers to the time required for a disinfectant to provide its maximum effect. And the answer is, of course, true. The disinfection time varies from agent to agent. It is the time that that particular agent must be applied in order for the disinfectant to be effective, and we can garner this information from the manufacturer's recommended protocols. Other definitions that we utilize in discussing disinfection and decontamination and so forth, the term aseptic. When we utilize the term aseptic, that means that we are absent pathologic organisms. An antiseptic is a product that destroys or inhibits the growth of microorganisms on living tissue. So unlike a disinfectant, an antiseptic is something that's applied to tissue itself. We sometimes use the term cleaning, and cleaning refers to the process that removes foreign material, and sometimes cleaning is required prior to doing or administering a disinfectant or sterilizing, because if we have certain foreign materials on, for example, a scalpel handle or a scissor or a hemostat, for example, that foreign material may interfere with the ability of the disinfectant to access the surface of that material. So the removal of foreign material, that is to say cleaning, is oftentimes required prior to the application of a disinfectant. When we use the term decontamination, That is any process that we follow that reduces the number of bacteria to a level where we feel it is safe to proceed with whatever process we are following. For example, we may decontaminate the skin or decontaminate the surface of a vial with an alcohol wipe. Now, what about the process of sterilization? Sterilization is most commonly performed in the podiatric offices with the use of an autoclave. And the term sterilization refers to any process. It can be physical, it can be through heat, it can be through radiation, but it's any process that kills all forms of life and other biologic agents, including any transmissible agents present within on a surface or within a certain area or within a volume of fluid or a medication or on instrumentation. So sterilization is distinct from other processes we've discussed, such as disinfection, in that sterilization will kill or deactivate or eliminate all forms of life and all forms of biologic agents. If you use chemical sterilization, this is a process known as chemosterilization, and agents utilized to achieve that are chemosterilants. We know that different organisms are susceptible or resistant to sterilization and disinfection. In general, most enveloped viruses and vegetative bacteria and fungi are relatively easy to kill. On the other hand, tuberculosis organisms, organisms in spore form, and prions are most resistant to sterilization. And so the strength and concentration we utilize and the time for disinfection under certain circumstances is dependent on the type of organism that we are attempting to kill. There are a variety of means by which we can achieve disinfection and sterilization, and generally they are either physical agents or they are chemical agents. Physical agents that can be used for sterilization and disinfection include various forms of heat, either dry heat or moist heat. It includes non-ionizing or ionizing radiation, or we could utilize various forms of filtration. Chemical agents for sterilization include a variety of either liquid or gaseous chemicals that result in the destruction of all organisms. And I would venture to say the majority utilize moist heat in the form of a autoclave in the office. However, there are other acceptable means to achieve sterilization and disinfection. A variety of chemical agents are available in the form of antimicrobials. Most of these work by the denaturation of the organism's protein or disruption of the membrane of the organisms. This includes various types of surfactants and heavy metals, such as silver nitrate, which is commonly utilized. They can include halogen compounds, such as iodine or chlorine-containing products, such as betadine. They can include a phenolic compound, which disrupts the membrane of the organisms. And again, an example of that is the phenol utilized in toenail corrections. Various aldehydes, again, work by denaturing proteins, and these are, again, very commonly utilized. Agents such as glutaraldehyde, Sidex. Ethylene oxide is less commonly utilized, certainly in the private practice, as it requires very special equipment and is a somewhat lengthy process to undergo. Sometimes oxidizing agents are utilized by healthcare providers, such as hydrogen peroxide, to disinfect a wound. So a variety of different chemicals, different structures are available for disinfection and sterilization, most commonly, again, working by denaturation of proteins. There are also a variety of physical agents that can be utilized to sterilize and disinfect. This can include moist heat in the form of boiling or autoclaving, and again, probably autoclaving at 121 degrees centigrade at 15 pounds per square inch for 30 minutes is the most commonly utilized technique for sterilization, and if this is done following cleaning to remove impediments to effective sterilization, this will literally kill all living organisms on the object being sterilized. Pasteurization is a form of moist heat that denatures proteins. Filtration can be utilized to reduce bacterial loads. And certainly those of us who are older remember the days that we would walk around hospitals, particularly entrances to the operating room, where there'd be ultraviolet lights and various forms of radiation utilized. These sterilize by affecting the DNA in the organisms, destroying the DNA or interfering with DNA production. So both chemical and physical agents can be utilized to achieve sterilization. Looking at radiation for a second, most commonly this will be in the form of either ultraviolet light or ionizing radiation. And again, I personally remember the days when you would leave the doctor's dressing room in the operating area and walk down hallways that were lit by various ultraviolet lights. These have limited ability to sterilize because they don't penetrate very deeply. They are helpful for decontaminating the air, and ionizing radiation can be utilized for various products. They're frequently utilized in sterilization of bone grafting and certain other healthcare products. Typically, this will be with gamma radiation. Ultraviolet light works by breaking the bonds between the cytosine, guanine, thymine, and so forth in the DNA. It distorts the DNA, so there's an inability of the DNA to replicate. Ionizing radiation, again, can affect the physical properties of some of the agents we utilize, such as bone graft substitutes. Again, it's going to typically utilize either beta or gamma particles, and is frequently utilized for packaged items, although the items themselves are not radioactive. Filtration can be utilized typically with a cellulose acetate filter, although there are other forms of filtration available. You want to remember that filtration is not a form of true sterilization. It does not remove small bacteria, mycoplasma organisms, or viruses, so that technically it does not destroy all living forms. So filtration, when you see that a product has been filtered, it is not technically sterilized, and we tend to utilize filtration for products that can be damaged by heat. For example, certain antibiotics, certain serum products, so that once again, filtration does not equate to sterilization. So here's our next question, true or false? Filtration does not kill all bacteria. And the answer is true. Filtration is not a form of sterilization. Filtration and filtered products that you may utilize on a patient will reduce the number of living organisms and reduce the number of bacteria, but do not truly sterilize. Heat is another classic form of sterilization, and those old enough to have taken microbiology in the old days remember the old Bunsen burner that we would utilize on our loops to sterilize before we would do various experiments. This was utilized typically in the office setting years ago for knives and blades and so forth. Another form of heat sterilization is a hot air oven, which would require a temperature of 160 degrees centigrade for 1 hour. There's also moist heat that can be utilized to achieve a form of sterilization. Classically, we all know about, for example, boiling water and placing objects in boiling water. One of the classic forms of trying to achieve sterilization was that of tyndallization, and the argument being that when you utilize boiled water, you do not kill bacteria that are in a spore form. So the process of tyndallization is an interesting one. One boils water for 20 minutes. You kill the living organisms in the water. You then cool and incubate the water for 24 hours. Any germs that are in a spore form would then start to grow. You then repeat the boiling process for 20 minutes. You then cool and incubate again. Allow any organisms in spore form to again regenerate, and then you do this a third time, so that the hope is that by boiling on each episode, you destroy the living organisms and allow the sporulating germs to then grow and then destroy them. And that's the form of tyndallization. We've also heard about pasteurization. Pasteurization is a process typically utilized for food products, and pasteurization reduces the number of bacteria so that it makes a food product or other product unlikely to cause disease, so that pasteurization, typically utilized for milk, does not sterilize. It reduces the number of bacteria, but again does not sterilize. And there are various methods for achieving sterilization. One can utilize a temperature of 138 degrees for just a fraction of a second. One can utilize a temperature of 71.7 degrees centigrade for 15 to 20 seconds, or a temperature of 62 degrees centigrade for 30 minutes. But again, we want to remember that pasteurization does not sterilize. It reduces the number of bacteria present. Probably the most common means by which we achieve sterilization in the office setting is the use of an autoclave. And in an autoclave, we place the objects we wish to have sterilized. We then seal off and close the chamber, and the air is replaced by saturated steam. The pressure within the autoclave then gradually increases so that the items are surrounded by steam under pressure. There is contact of the surface of these objects being sterilized with the hot steam under pressure. There is condensation, releasing the heat of condensation, and all microorganisms are killed. Typically, an autoclave is utilized at a pressure of 15 pounds per square inch at a temperature of 121 degrees centigrade between 15 and 30 minutes. If you increase the temperature, you reduce the time required for sterilization. Here's our next question. True or false? When properly performed, an autoclave kills all bacteria. When properly utilized, an autoclave kills all bacteria. True or false? And the answer is, of course, true. Unlike other processes such as pasteurization or filtration and tyndallization, we know that when utilized at the correct pressure and the correct temperature for a correct time, autoclaves do kill all bacteria. Looking at the use of the autoclave, for example, we know that there are some variations in technique. If you have an unwrapped metal instrument, then one can utilize a temperature of 132 degrees centigrade for 3 minutes at 27 pounds per square inch. If you have an unwrapped instrument combined with some porous materials on the instrument, a temperature of 132 degrees centigrade for 10 minutes is required, again at 27 pounds per square inch. If you have unwrapped instruments, packs, bulk loads with porous or non-porous which would be, I think, a more typical scenario. Here again, a temperature of 121 degrees for 30 minutes at 15 pounds per square inch is required. So there are differences in how long one requires the autoclave process to on-go, whether or not we're just putting an instrument in that's not covered, instruments that are covered, or instruments that are in packs, or instruments that have porous materials such as rubber handles attached to them. Here's our next question, true or false? For wrapped instruments, proper autoclave settings are 121 degrees centigrade for 30 minutes at 15 pounds per square inch. So you're going to autoclave wrapped instrumentation, and the answer is, of course, true. For wrapped instrumentation and instrument packs, proper autoclave setting is 121 degrees centigrade for 30 minutes at 15 pounds per square inch. Looking at the autoclave for a minute, there are many advantages to the autoclave. We know that it kills spores and sporulating bacteria. Over the long haul, it's probably the least expensive means by which to achieve sterilization. It is certainly the safest and quickest means to assure sterilization. Autoclaving is non-toxic, and certainly autoclaves are readily available to the average podiatric physician. The disadvantages of autoclaving include that the unit must be properly utilized, so there's certainly room for human error, and you cannot utilize an autoclave for heat and moisture sensitive items. We also have this concept of flash sterilization, and that's most commonly something that comes up in the operating room in the surgery center or hospital, and that's a process that's utilized to sterilize unwrapped items that may have been dropped before or during a procedure. So there may be a critical item during surgery that's dropped on the floor, becomes contaminated. We can't complete the surgical procedure without that item, and so we request that flash sterilization be performed. Another indication for flash sterilization would be the unanticipated need for some instrumentation or implant, something that occurs during the surgery where we realize we need some additional equipment that has not yet been sterilized. Oftentimes, flash sterilization is utilized too frequently. For example, you may have a hospital or surgery center that says, well, we're running 3 rooms, and someone else just finished with the equipment, and rather than have the necessary numbers of sets or necessary equipment, the hospital or surgery center will say, well, we'll wash this and flash sterilize the instrumentation. And so that's not uncommonly a cause for the need for flash sterilization. Or sometimes we've called ahead, made arrangements for equipment, and the rep shows up at the last minute. Perhaps they're late getting to the surgery center or hospital, and they have not had the opportunity to have the equipment properly sterilized. Flash sterilization can be performed several ways. If it's a non-luminated, non-porous metal object, then it can be flash sterilized at 270 degrees Fahrenheit or 132 degrees centigrade for 3 minutes. If it's a metal object that has is porous or illuminated, then if it's a gravity sterilizer, 10 minutes is required. If it's a pre-vacuum sterilizer, 4 minutes required at 130 degrees centigrade. And if it's something like power tools, rubber hoses attached to the power tools, or something that's illuminated, then you really have to look at the manufacturer's recommended protocols for flash sterilization. Now, the Center for Disease Control has specific policies with regard to flash sterilization, and it's considered acceptable for processing cleaned items that cannot be packaged, sterilized, or stored before use. And again, the CDC recognizes that flash sterilization is sometimes utilized when there's insufficient time to sterilize an item by the preferred standard techniques. However, it's important to recall that flash sterilization is not as effective as standard sterilization, and therefore you don't want to utilize flash sterilization just as a convenience or as an excuse for the hospital or surgery center not to buy the equipment that they really should have. And just saying, well, we only have one set, but we scheduled 3 podiatric surgeries for the same time. Flash sterilization is not recommended for implantable devices, devices that are going to remain in, such as screws, intramedullary nails, joint replacements, and so forth. However, it may be unavoidable in some circumstances, and if a flash sterilization is going to be performed on an item that's going to be left implanted in a person, then a log has to be maintained with the patient's name, the hospital identifier, the biological indicator result showing that successful flash sterilization had been performed, so that tracking can occur in the event that there is an adverse outcome in a particular patient. I have seen personally malpractice cases involving infection that have occurred following flash sterilization. In looking at the effectiveness of autoclave sterilization, a number of factors are important, including the size of the object being sterilized and how that object is wrapped. In other words, is the object wrapped in such a way that it allows penetration of the steam and pressure. The temperature and moisture level, as well as the pressure, are important. The type of bacteria or viruses or organisms that one wishes to kill is a consideration. You want to remove any soil or dirt or other debris by cleaning before autoclaving, whether or not you have the instrument open or closed, for example, a scissor, and the type of autoclave utilized. These are all considerations in effectiveness of the autoclave itself. In monitoring of the autoclave, it is required that you maintain records showing that the autoclave has been monitored and that the process itself has been monitored and shown to be effective. There are 3 basic ways in which autoclaves can be monitored. There are physical agents, or physical methods, such as the use of a thermocouple, which monitors the temperature accurately. There are chemical indicators, that is to say, there are heat-sensitive chemicals that will change color with having achieved the proper temperature as well as exposure time. And then there are biologic indicators in which you utilize spore-bearing organisms which are added during the sterilization process. They are then cultured to show that these spore-forming organisms have been killed. So mechanical monitors are available on the autoclave themselves. They confirm the time and temperature and pressure, and they tell you that the autoclave has in fact been working properly. And there are various recorders and gauges and chart recorders and so forth, and printouts can be kept on file for reference if required. The chemical indicators are frequently utilized by podiatric physicians, and these are heat-sensitive tapes. Generally, they're in the forms of strips, and they are impregnated with a thermochromic ink that will change color when the appropriate temperature and appropriate time has been reached. So what they tell you is that the package has been exposed to sterilization, but it does not indicate the sterility of the contents. It merely tells you, yes, the autoclave was functioning properly. However, It does not tell us whether or not there was penetration of an appropriate level to achieve sterilization. The best means are, of course, biologic indicators, and these are living, non-pathogenic spore-forming bacteria. Typically, they are Bacillus subtilis or Bacillus styrothermophilus, and these are placed inside the autoclave packages. They indicate the sterility of those organisms, and this is done weekly to monitor the autoclave to ensure that the autoclave is achieving conditions such that it is killing the spore-forming organisms. Now, once you autoclave an object, one of the questions is how long is it sterile after you autoclave? And the current national standard is what is known as event-related sterility. And that is to say, once an item is sterilized, the sterility is determined by how you handle that package after it's been sterilized. So it's not really time related. There's no expiration date, if you will, on sterilization. It's whether or not some event has occurred that could have compromised the sterility of that package. Years ago, expiration dating was utilized. However, it's now considered that once sterilized, the consideration for contamination is event-related, and items are considered to be sterile indefinitely unless the package becomes compromised. Perhaps it gets wet or torn, or there's a puncture wound, not puncture wound, but a puncture, or some reason to believe that the sterility has been violated. So the shelf life of any sterilized package, again, is not time related, but is event related, and provided that there's no break in the packaging, the item is considered to be sterile essentially indefinitely unless it becomes wet or again you find some puncture or tear. However, you'll find that each healthcare facility probably has its own policy, and probably for the purpose of your own office and your office manual, you also want to include some type of policy as to how long you consider the shelf life to be appropriate. So this is our next question: true or false? Each facility and or provider will have a unique policy and procedure regarding shelf life of a sterilized instrument. And the answer is, of course, true, that the sterilization is considered to be event-related, and it is up to you in your particular office or the individual institution to determine how long they are comfortable with items being considered to remain sterile. Chemical sterilization is frequently utilized in various healthcare facilities as well as offices. We tend to utilize chemical sterilization for heat-sensitive materials such as plastics or scopes, various instrumentations that we feel can be damaged by the use of heat under pressure. One of the commonly utilized forms of chemical sterilization, again for orthopedic devices and sometimes grafting materials, is that of the ethylene oxide chamber. Now, ethylene oxide is an alkylate, and it inactivates the DNA in microorganisms. They are mixed with inert gases in order to deconcentrate these agents and prevent an explosion. So, for example, neon or freon may be utilized. They require a relatively high humidity, 50 to 60%. Generally, the sterilization process is carried out at a temperature between 50 and 60 degrees, and it's a rather lengthy process. Ethylene oxide chambers take about 4 to 6 hours to be effective. Activated 2% glutaraldehyde is also utilized typically in the office. In utilizing glutaraldehyde, we place our cleaned instrument in solution for 20 minutes. If we're concerned about spores, then it can take 2 to 3 hours to achieve sterilization. Looking at ethylene oxide for a minute, this is an agent that is very toxic to body tissues and is a known carcinogen. As mentioned earlier, it is explosive, highly flammable if it's not mixed with something such as neon or freon. Generally, it's utilized at a concentration of 10%. In order to achieve disinfection and sterilization with ethylene oxide, the instruments must be dry prior to sterilization. Ethylene oxide is expensive. The process can take as long as 10 hours, and following sterilization, the items must be aerated to reduce toxic residue. So, as mentioned earlier, ethylene oxide is not something that's typically utilized in the podiatry office. It is something utilized more in facilities and for manufacturers of certain heat-sensitive products. Following ethylene oxide sterilization, aeration is required. This can take up to 12 hours and a very, very long process. There must be exhaust systems that are separate from the hospital or office ventilation system, as these are carcinogenic and toxic products. So practically speaking, ethylene oxide is not something utilized in the office setting. It is used by manufacturers and sometimes healthcare facilities. The monitoring of an ethylene oxide sterilizer is with use of Bacillus subtilis, again a spore-forming bacteria, and it is tested with each cycle. So here's our next question. True or false? Ethylene oxide is highly toxic to body tissues and is a known carcinogen. And the answer is true. Ethylene oxide is highly toxic and is a known carcinogen. I want to move on from the process of sterilization to the process of disinfection, because disinfection is something commonly performed in the office setting. And again, when we use the term disinfection, we're talking about the destruction of pathogenic organisms, viruses, bacteria, fungi, and their toxins by exposure to some type of chemical or physical agent outside of the body or on the skin. They, again, may not be sporicidal, so they may be sporostatic. Just to recall once again, we want to look for any particular agent at the disinfection time, the time that is required for the disinfectant to achieve its effect. And we want to recall, as mentioned earlier, that the disinfection time is related in part to the potency of the disinfectant and what it is we're trying to kill. And so organisms such as prions or tubercular bacteria are more resistant than certain other organisms. And then we have, of course, the term terminal disinfection, the disinfection of a room following a procedure. There are recognized levels of disinfection, and we have high-level disinfection and we have low-level disinfection. Low-level disinfectants mainly kill vegetative bacteria and some fungi and a narrow range of viruses. Intermediate levels of disinfection will kill enveloped viruses such as hepatitis B, HIV virus, fungi, tubercular bacteria, vegetative bacteria, and some spores and spore-forming bacteria. High-level disinfection will kill a large number of spores and spore-forming bacteria, as well as vegetative bacteria, tubercular, bacilli, fungi, and viruses. So that we need to determine or recognize the fact that there are these levels of disinfection and sterilization. Non-critical disinfection or sterilization would be for objects that come in contact with intact skin. For example, it may be a Doppler, it may be a tuning fork, it may be an ultrasound head. And since these are not coming in contact with violated skin, only an intermediate to low level of disinfection is required for this type of instrumentation. Semi-critical disinfection or sterilization is utilized for objects that come in contact with non-intact skin or mucous membranes. For example, a thermometer, or an instrument utilized to, for example, probe a wound. And here a high level of disinfection or so-called semi-critical disinfection is required. Critical disinfection obviously would be objects such as surgical instruments, the use of needles on syringes and so forth. And here sterilization is essential, typically with an autoclave or ethylene oxide. And these are instruments that enter the body tissues themselves. We had mentioned earlier that a variety of methods of sterilization and disinfection are available, and this can include various chemicals and gases, filtration systems, radiation systems such as ionizing and non-ionizing radiation, dry heat as well as moist heat. And again, we want to recall that the chemical disinfectants and sterilants, the chemical antimicrobials, typically work by the denaturation of the organism's protein or disruption of the membrane of those organisms. And this can include alcohols, it can include phenol-based compounds, aldehydes, various oxidizing agents, or heavy metals. So the question arises, what about resistant bacteria? We hear more and more about resistant bacteria. And we know that increasingly we are seeing organisms against which antibiotics are less effective or even ineffective. So when we have these organisms that demonstrate increased resistance, we refer to them as resistant bacteria. And does this imply increased resistance to the disinfectants that we would utilize in the office? It turns out that reduced susceptibility to disinfectants does not correlate with the failure of the disinfectant, because the concentrations of the disinfectants typically greatly exceed the cidal level for that bacteria. So when we utilize the term resistance in terms or with reference to bacteria, this does not imply increased resistance to a topical antiseptic or the disinfectants or sterilization process. So we have no good data that would suggest that antibiotic-resistant bacteria are somehow more resistant to disinfectants, chemical disinfectants that we typically use in the office. And again, that is because the chemical antimicrobials we are utilizing are at very high concentrations, far in excess of the concentrations required to kill those germs. What about the issue of methicillin-resistant Staphylococcus aureus or vancomycin-resistant enterococci? These are, of course, important considerations, and again, we know that there is reported increased bacterial resistance of these organisms, and the question is whether or not your antiseptics need to be altered because of these resistant organisms. And the answer is really a no. For the most part, The topical antiseptics and disinfectants that we utilize in practice are very effective against resistant MRSA and VRE. And this is because, again, the concentration of these disinfectants are much higher than the minimal inhibitory concentrations required for these disinfectants, even for the more resistant strains, so that there's really not a correlation between the antibiotic resistance pattern of the organism and the ability of that organism to be killed by disinfectants due to the rather significant concentration of these disinfectants. And this includes a variety of drug and multi-drug resistant organisms, period. Can disinfectants induce resistance? We know that antibiotics with bacterial exposure can lose their effectiveness, and bacteria can develop a resistance to certain antibiotics. So the question is, can this occur with the use of disinfectants? However, and there is data to show that with constant exposure to the same disinfectant, that enhanced tolerance can occur in bacteria. However, does that enhanced tolerance correlate clinically to any significant resistance? And the answer is no. And again, this is because the effectiveness of the disinfectant is enhanced by that significant concentration well above the MICs. So that while it is true that bacteria can develop some increased ability to resist it does not reach a clinically significant level of concern. What are some of the factors that influence the effectiveness of a disinfectant? One of the most important factors is time, and making sure that we are following the disinfection time and allowing the object or instrument to be disinfected, to be exposed to that disinfectant for a proper period in order to allow it to do its job. Temperature makes a difference. Generally, the higher the temperature, the more effective disinfectant. Obviously, the concentration of the disinfectant. The greater the concentration, the more effective the disinfectant is going to be. You also want to consider the actual disinfectant itself. We showed a list earlier of the various chemical agents that can be utilized as chemosterilants and disinfectants. Not all of these agents are equally effective, and they're not all equally effective for the same organisms. For example, something like chlorhexidine has greater activity against gram-positive cocci, such as staphylococci or streptococci, as opposed to gram-negative bacteria, say Klebsiella or E. coli. We also want to remember this issue of cleaning. Disinfectants can be inactivated by organic matter and dirt left on instrumentation and surfaces. The disinfectants may not be able to penetrate to the surface of the object, getting through dried blood or pus or mucus or feces. It may not be able to penetrate through cork or plastic. So we want to make sure that we are properly cleaning instrumentation before disinfecting in order to enhance the effectiveness of the disinfectant. So here is our next question. True or false? Disinfectants may be inactivated by blood and pus, which is not cleaned off prior to disinfection. And the answer is, of course, true. It is important to clean and remove blood or pus or mucus or any other dirt on the surface of instrumentations so that they do not directly inactivate or disallow penetration of the disinfectant to the underlying object. So cleaning is very, very important as the initial step in disinfection. What about resistance to the killing of bacteria by disinfectants? Generally, gram-negative organisms are somewhat more resistant than gram-positive organisms to disinfectants and antiseptics. Mycobacteria and certain other organisms are also resistant to disinfectants and antiseptics. We know that certain viruses are more resistant than others to disinfectants and antiseptics. Once again, it is important to note that the colder the temperature, the less effective antiseptics are. The warmer the temperature, the more effective antiseptics are. If you're going to err, you err in terms of longer exposure of the instrumentation to the antiseptic. So generally, disinfectants and antiseptics work better the longer they are applied, and in general, the higher the concentration of the antiseptic or disinfectant, the more likely this is to work, although this is not always the case. Now, what kind of disinfectants can we be utilizing in the office setting? We have a variety of chemical classes, including phenols and phenolics. We have hexachlorophene, we have triclosan. The phenol and phenolics are less commonly utilized. These work by denaturation of the organism's proteins. They injure the cell membranes and inactivate microbacterial enzyme systems. Generally, they are not sensitive to organic matter and are stable. Some of the phenolic compounds would include things such as Lysol. We have hexachlorophene, commonly utilized for staphylococci and streptococci, as hexachlorophene is rather effective for gram-positive cocci, and triclosan, which is broad spectrum and is effective against both gram-positive and gram-negative organisms, as well as against fungi. Hydrogen peroxide is frequently utilized as a disinfectant. It is generally in a 3% solution, and it does provide a high to intermediate level of disinfection and is very helpful in reducing bacterial count. Phenolic compounds would include commonly used products such as Lysol, and phenolic compounds in general provide an intermediate level of disinfection. Biguanides are typically utilized in the form of chlorhexidine. It resembles chemically hexachlorophene. There are iodine-containing compounds such as betadine or isodine that affect cellular enzyme systems and cellular proteins. They are frequently utilized as topical agents and again are effective for disinfection. Chlorine compounds provide an intermediate level of disinfection. They're frequently utilized in some form in wound cleaners. And this would include the wound cleaners containing some form of sodium hypochlorite. And they do kill spore-forming organisms, including anthrax. Alcohol is frequently utilized as a disinfectant. Typically 70% ethanol or isopropyl alcohol is utilized. In using alcohol, a concentration between 60 and 95% is required. An exposure time of 5 minutes is required. Alcohol is simple to utilize. It provides an intermediate level of disinfection. It is helpful as it is bactericidal as well as fungicidal. It is not active against certain spore-forming organisms or non-enveloped viruses. It does enhance the activity of other agents. Here's our next question. True or false? Alcohol kills bacteria and fungus organisms. True or false? The answer is, of course, true. Alcohol is a reliable disinfectant and antiseptic in proper concentration, killing bacteria and fungal organisms. Heavy metal disinfectants are not infrequently utilized. They have small amounts of heavy metals such as silver nitrate, which is commonly utilized for cauterization in the office setting. Another common heavy metal that's utilized is silver sulfadiazine, which we frequently utilize in wound care. Mercuric compounds, a little less commonly utilized but are highly bactericidal. Examples of that would be old-time mercurochrome, which was a bit less irritating and less toxic. Copper sulfate has classically been utilized for the treatment of fungi. At one time was very popular as a foot soak. And of course zinc chloride and zinc oxide, typically utilized in various wraps and treatment of wounds, commonly utilized as an active agent in various mouthwashes. Peracetic acid, or styrus, is not infrequently utilized to sterilize endoscopes. The use of peracetic acid generally takes about 30 minutes, and the instrument's utilized immediately after sterilization. Glutaraldehyde, particularly Sidex, very commonly utilized for disinfection. Generally, Sidex is utilized at a 2% concentration. It provides a high to intermediate level of disinfection. And again, I think we utilize Sidex and glutaraldehyde products primarily in scopes and instruments which are heat sensitive. However, it must be used at a proper time. Quaternary ammonium compounds provide a low level of disinfection. We frequently will utilize quaternary ammonium compounds for cleaning of walls, examination chairs, and tables. One of the problems with quaternary ammonium compounds is they're easily inactivated by blood and pus, and therefore good cleaning should precede the use of quaternary ammonium compounds. They're much more effective against gram-positive organisms than gram-negative organisms, against which they have very little, very poor effect. Now, what about blood-borne pathogens? We have, of course, hepatitis B. We have HIV concerns. And we also have to consider multi-drug resistant tubercular organisms in these patients. And therefore, this is a major consideration in treating such patients if they are part of your practice. With such patients, tuberculocidal disinfectants or the use of hypochlorite solution must be considered, and this is because we want to inactivate and destroy these organisms. So a higher level of disinfection is required in treating these patients. In looking at OSHA requirements in these patients who are hepatitis B or HIV positive, all equipment and environmental and working surfaces are supposed to be cleaned and decontaminated with an appropriate disinfectant after contact with blood or infectious materials in these patients. Now, here again, OSHA does not specify the specific disinfectant or procedure, but you want to utilize a disinfectant that's at a higher level in order to destroy these organisms, and consider using a disinfectant that is tuberculocidal as well as virucidal. The question then becomes, is routine surface disinfection necessary? And the question is, if it's a non-critical item, then routine germicidal disinfection is probably not required. So this would be, for example, the need to disinfect the examination chair or examination table from patient to patient. And this is not required if there's no break in the skin, if there's no blood or pus or other significant contamination which has occurred. What about instrumentation, such as a blood pressure cuff, a Doppler, an ultrasound probe, things that we use from patient to patient? And the answer is that these can become contaminated with infectious agents. They can contribute to the spread of organisms, and generally non-critical medical equipment should be disinfected with at least a low, if not intermediate level disinfectant. So examples of this would include scissors utilized to remove bandages from patient to patient. Again, equipment utilized for taking, for example, ABIs, Dopplers, X-ray stands, these types of surfaces. And of course, the most important thing, wearing gloves when examining patients and washing hands between patients, very important vector that we can easily control. Some other considerations in using disinfectants. Make sure that you are familiar with the manufacturer's recommendations regarding each disinfectant. Some disinfectants are in concentrations that allow dilution. However, there are some disinfectants that are not supposed to be diluted. So make sure that when you prepare the disinfectant for use, that you're following the directions and using the disinfectant accordingly. Another consideration is the fact that disinfectants must be stored properly. There are some disinfectants that, if stored at an improper temperature or stored in an improper manner, will lose their effectiveness. You also want to make sure that the disinfectants are being in appropriate containers, being stored in appropriate containers. And here again, a disinfectant in a contaminated or dirty container may very well lose its effectiveness. So when utilizing disinfectants, familiarize yourself, make sure the staff responsible for using the disinfectants are familiar with the recommended protocol as described by the manufacturer for mixing and for storage and of course for use. Another consideration in using disinfectants is the instrument itself. Take something like a scissor, for example, or a hemostat or some other object with a hinge or pivot. These instruments should be cleaned and opened in order for the disinfectant to be working at its maximum. So, for example, if you have a closed instrument, a closed hinge, a closed scissor, for example, and it's in the disinfectant may not reach, it may not penetrate the surface that requires disinfection. So the effectiveness of that disinfectant requires you to clean that instrument, open it so that the disinfectant can penetrate the hinges and get to the areas it needs to get to provide disinfection. In looking at the use of your office disinfectant, as a general rule, we know the more concentrated the disinfectant, the more effective that disinfectant is going to be, and the shorter the time is going to be that is necessary to achieve killing of all the organisms. However, if you start to dilute out disinfectants, keep in mind that not all disinfectants are equally affected by dilution. For example, if you're utilizing a quaternary ammonium compound, you can reduce the concentration without necessarily seriously reducing its effectiveness. On the other hand, if you dilute a phenolic compound, you significantly reduce the ability of that compound to kill. So here's our next question, true or false? The more concentrated the disinfectant, the shorter the disinfection time. And the answer is, of course, true. The more concentrated the disinfectant you're using, the less time it takes for the disinfectant to achieve its goal of killing the microorganisms on the surfaces of the organisms. Now, we spoke about the disinfectant time, the contact time, and we had suggested that each compound has a recommended disinfection time. The question becomes whether or not this is practical. For example, disinfecting between patients. We know, for example, that for many products, if not most products, the disinfection time for hepatitis B virus or hepatitis or HIV virus or tuberculosis virus is a contact time of 10 minutes. So what do we do given the fact that we frequently turn over these rooms and turn over these patients with a less than 10-minute contact time between the instruments and the disinfectant? Is this considered appropriate? And the fact is that this has been studied, and it's generally felt that a contact time of 30 to 60 seconds is generally considered to be adequate for most needs. So while it is true that most products, particularly with reference to hepatitis B, HIV, and tuberculosis, recommend a contact time of 10 minutes, in reality, most studies have shown that a contact time of somewhere between a half a minute and 1 minute is sufficient for our needs in office practice. There are some disinfectants that have a registered contact time of 1 to 3 minutes, and in theory and certainly by law, if you're using these disinfectants, you are supposed to follow the appropriate instructions, so be certain that you are familiar with the contact times for the various agents. As far as duration of exposure goes, again, we've been talking about the fact that we want to utilize these disinfectants at a proper contact time. These studies that have been done on this subject show that the effectiveness of the low-level disinfectants against vegetative bacteria, yeasts, mycobacteria, and viruses occur, again, between 30 and 60 seconds, period. When we utilize these agents at less than the recommended time, however, you want to remember that if there is an infection, the user is assuming liability for any injury that occurs because you're essentially using these as an off-label and not following the recommended time. Cleaning is also critical, and we've mentioned the fact that cleaning prior to sterilization or disinfection is very, very important. As far as cleaning goes, we recognize that the higher the number of microorganisms, the larger the amount of contamination, the more time the germicide needs to destroy these organisms. And we certainly want to make sure that instruments are cleaned before disinfection and sterilization, because when we clean the instruments, we reduce the number of microorganisms that must be inactivated. Therefore, we reduce the disinfection time. And one remember that certain things, such as blood and pus, will act as a physical barrier to the disinfectant. Plus, many times blood or pus or mucus other biologic agents will directly inhibit the germicidal activity of the disinfectant. So cleaning is absolutely critical before disinfection for a number of reasons. So any organic matter that is present in the form of serum or blood or pus or any type of lubricant material, for example, in association with Doppler or ultrasound, can interfere with the antimicrobial agent of activity of the disinfectant. So again, there can be a direct interaction between the material on the surface of the object and the germicide, which leads to decreased effectiveness, inactivation of the disinfectant. And then there's the fact that we have the inability of the disinfectant or germicide to penetrate and get to the surface. So we can't stress strongly enough the need for cleaning prior to disinfection, and the fact that disinfection is not an excuse not to clean. So here's our next question: true or false? Blood and pus should be cleaned off the instruments prior to disinfection. And the answer is true. Blood and pus should be cleaned off instruments to allow better penetration of the disinfectant to the surface and to avoid the potential of interaction and inactivation of the disinfectant by the biologic material which remains on the instrument. So certainly when we finish a procedure and we have a scene that looks something like this, we certainly want to clean off the blood and other organic matter before proceeding with the institution of disinfection. We also want to remember that we have this concept of biofilms. We have microorganisms that grow on surfaces and produce a polyglycocalyx or slime layer that protect the organisms from attack, including attack by disinfectants, so that by cleaning of the instruments, we are removing the biofilms. And this is important because bacteria that do produce biofilms are more pathogenic. They're more resistant to antimicrobial activity. This is one of the reasons that when we have infected hardware, we need to remove the hardware when the patient is not responding to seemingly appropriate therapy. So that, again, one more good reason for the need to clean instruments before proceeding with disinfection. In looking at this concept of cleaning before disinfection, we want to remember that cleaning is critical in order to achieve high-level disinfection. One of the things that is helpful to do is frequently to pre-soak the instrumentation and rinse them before even cleaning in order to soften any dried pus, dried organic material, which will again adhere to the surface of the instrumentation and interfere with effective disinfection or sterilization. Now, what about cleaning between surgical cases? Generally, the recommendations are that all operating rooms or procedure rooms should be cleaned between cases. This includes the removal of any linens or waste into the appropriate transporter bags, any beds, tables, operating room chairs or procedure chairs, furniture, anything that came in contact with patient fluids should be disinfected, and a disinfecting floor mopping procedure should be in place. If you have a procedure room or operating room, walls and ceilings should be cleaned and disinfected on a weekly and monthly basis. as well as any lights, monitor screens and monitors. Air vents and grills need to be cleaned, and storage cabinets and supply areas need to be cleaned to remove any dust or debris. Terminal cleaning is generally performed after the final case of the day. It should be performed in any event once weekly. Terminal cleaning should be performed following any, quote, dirty case, particularly those where there's MRSA or vancomycin resistant or intermediate sensitivity Staph aureus, any exposure to tuberculosis organisms, flesh-eating strep, Ebola. In those cases, the OR should be shut down or the procedure room shut down for 48 hours. Question: true or false? Terminal cleaning of a room should be performed following cases contaminated with MRSA. And the answer is true. Terminal cleaning should be performed following any cases contaminated with MRSA. What about endoscopes? We know that endoscopes generally cannot be exposed to autoclave disinfection. We want to make sure that any disinfection protocol for endoscopic instrumentation eliminates hepatitis C virus from the surfaces, and generally 2% glutaraldehyde for 20 minutes is helpful in preventing transmission of that organism. The CDC recommends high-level disinfection for hepatitis B, hepatitis C, HIV, or tuberculosis organisms. For endoscopic instrumentation, which is contaminated, we know that high-level disinfection is useful for the use of endoscopes to prevent transmission of these organisms. We have to be careful in working in facilities, particularly surgery centers, where there's a high turnover of patients utilizing who have had endoscopic procedures. You might think that you could take a history and do a physical examination and say, well, my patients are not HIV positive, they don't have hepatitis B, so we really don't need to follow a high level of disinfection or sterilization. But the fact is that you really cannot rely just on clinical and historical findings to determine whether a patient is or is not HIV positive or hepatitis B positive. The assumption is that all patients are potentially infected, and therefore disinfection should proceed with the assumption that the patient was in fact infected. In summary, the state of Missouri requires training in infection control, prevention of the transmission of infection for all podiatric physicians and employees in the office. This training session is offered in an effort to provide that training. Thank you for your attention and concern to this matter.